Good afternoon, and welcome to the meeting of the Arlington County Police Practices Group. This is a meeting of the Mental Health Subcommittee as part of the larger Police Practices Group. This afternoon's meeting is being broadcast on our governmental channels, both Comcast and Verizon, as well as our YouTube channel and on Facebook. This afternoon, we have a couple of subject matter experts that are going to engage with the Mental Health Subcommittee, making some presentations and engaging in some questions and answers. If you are watching this on the Facebook stream or the other channels available to you, you won't be able to ask questions today, but you will be able to go to the county's website where we have a form established for you to choose a subject that may be of interest to you. And when you click on those subjects, you will get a question box and you will be enabled to either ask a question or make a comment relevant to one or all of the topics that are under consideration by the Police Practices Group. So we are looking for a spirited and engaged conversation today, getting some professional expertise to weigh in on the very important topic of police practices and mental health. And with that, I will turn it over to the subgroup chair, Naomi Verdugo. Naomi, all yours.
Thank you, Jim. I'm Naomi Verdugo. I chair the Mental Health Subcommittee of the Police Practices Group. Today, I am joined by members of our subcommittee, which include Dave Fitzgerald, a member of Arlington's Community Services Board, Whitney Kernoodle, co-founder of Black Parents of Arlington, First Sergeant Matt Puya of Arlington County's Police Department, Brian Stockton, Chief of Staff of Arlington Public Schools, and Cicely Whitfield, Director of Programs with Bridges to Independence, which focuses on ending homelessness. I am really honored today to welcome our two guest speakers, Judge Steve Leifman of the 11th Circuit Court in Miami-Dade, and his biography, which we sent out with some of the publicity, is extensive and impressive. Besides winning lots of honors and awards, and being the subject of a PBS documentary called The Definition of Insanity, which I hope you watched. He has also been special advisor on criminal justice and mental health and substance abuse issues for the Supreme Court of Florida. He is currently the co-chair of the American Bar Association's Criminal Justice Mental Health Committee and co-chair of the Judges and Psychiatrists Leadership Initiative. We are really honored to have him here. He has been leading a mental health court for 20 years. We are also delighted to have John Snook, Executive Director of Treatment Advocacy Center. It is a nonprofit and a leading mental health advocacy group, and we're lucky to have it headquartered right here in Arlington. John and his organization have been instrumental in helping to change state laws in over half our states. One of their main focuses is decriminalizing mental illness. With that, I will turn it over to you, John Snook. Thank you for being here.
Thank you so much for having me, Naomi. And I have to start by saying that having Judge Leifman here is such an honor. Honestly, much of what I'm going to talk about, you're going to then hear Judge Leifman say, I did all of this on the ground. Really, honestly, many of the solutions that communities across the country are coming to are things that Judge Leifman's been saying for more than a decade, for 15, 20 years. And unfortunately, in Virginia, this has been a very common issue for discussion at the state and local level. I sat on the Virginia Tech Commission and the Civil Commitment Group in 2007 following the Virginia Tech tragedy. And one of the big discussions we had there was these same issues about getting people treatment early and keeping people engaged with care and not requiring law enforcement. And unfortunately, that issue has continued in Virginia and across the nation. The issues around the criminalization of mental health and the inability to provide effective care for especially individuals who are the most seriously ill is the topic that we talk about every day, and now we see in the news almost every day. I think we're really getting to an inflection point, and I'm hopeful that solutions like those that Judge Leifman has been advocating for years are really starting to hit the ground. And what we're talking about at the end of the day is quite simple, that unlike other medical emergencies, mental health and behavioral health emergencies too often result in a law enforcement response. We released a report last year that found that 1/5 of officer time nationally is spent responding to or transporting someone with a mental illness, and that it comes out to just about $1 billion every year that is spent, again, not on treatment, not on ensuring that people get and stay well, but simply on transporting people back and forth from facilities to facilities. That's, for all intents and purposes, entirely wasted resources. And I think if you talk to any officer on the beat, they will tell you that same thing, that they're not dealing with criminals here, that these aren't issues that they feel like they are addressing from a criminal justice perspective because that's the proper place. It's just that there's no one else to do it. Virginia, for its part, has really stepped up, especially following the tragedy involving the governor and his son, to make changes, to allow communities on the ground to really provide the level of care that we know needs to happen. And what that means, quite simply, is stepping away from crisis, responding to someone before they're in that point that they pose a danger to themselves or someone else, which too often has been the standard for care in Virginia. So what that means is providing a solution that has no wrong door and that doesn't wait for people to get so sick before they can be helped. What does that look like on the ground? It's honestly different in almost every community. The realities of Oregon and the CAHOOTS program are different than Dallas and their Right Care program. Tucson's model may not be exactly the same as what we see in Massachusetts, but there are some common underpinnings that I think we all can engage in and really make sure we have as proper baselines for a successful system. So one of the first things we talk about is training, that law enforcement needs training to be able to address these issues. But too often what we see in communities is that's where the conversation stops, that this again remains a law enforcement problem. And the reality of the system is that it cannot be the case. We are never going to train our way out of this problem. So what we advocate is for what the folks who run the crisis intervention training program nationally argue, is that CIT training, that best-in-class mental health training that law enforcement officers receive, is part of a program, not a training in and of itself. It is making people part of an effective mental health system, even if they are coming through that system from a criminal justice lens. And I think that's a really important point that Virginia should take up and really engage in more strongly, is that idea that law enforcement training is vitally important, but it isn't a solution in and of itself. Virginia's also done a really nice job in starting to step in on some of those other issues that, being an Arlingtonian myself, I've seen over and over again. The issues that we see too often of someone needing care and being told there's no treatment available anywhere near here. We're going to have to drive you down to Richmond. You're going to go to Western State. That law enforcement officers may spend hours driving someone to find an available treatment bed, or sit in the emergency room being boarded because we simply waited too long and there's nowhere for them to go. And I've been very, very pleased at the work that Virginia has done to start to step up and provide resources to both address that transportation process and also ensure that there are enough treatment beds, both inpatient and crisis beds, to ensure that individuals aren't trapped in those inappropriate systems. Because the reality is, as people get trapped in those systems, they end up being pushed into the one system that can't say no. and that's our jails. And Arlington, Virginia proper, just like the rest of the country, criminalizes far too many people with serious mental illness. The numbers vary, but at its lowest, most communities agree that at least a quarter of their population has some level of mental health or substance abuse disorder. And almost every community agrees that there are a significant number of people who are in those facilities inappropriately, who could be better served in other facilities. What do we talk about when we talk about doing things more correctly? I think there are a host of solutions. Judge Leifman's going to talk to you about some of the ones that have worked in Miami-Dade and other communities that really, they're so good they've made a movie about them. They really are what you're looking for, and they've got some really good pieces to them that a lot of communities can engage in. But what we're talking about at the end of the day is ensuring that these systems provide care with people they know before they get sick. And so if you look at a program like in Tucson or in Dallas, what we're talking about is providing people ongoing care at whatever level of need they need. And what that looks like on the ground is something that Virginia has struggled with for a while. And many families have reached out to my organization and have said, here in Virginia, too often what we hear is they're either sick enough for inpatient care or they're on their own, that they aren't engaged in community services. And if the services are entirely voluntary, they struggle very much to engage that population. And so where these systems are moving is really focusing on amply funding and prioritizing, providing those individuals a significant level of care before they reach the crisis stage. But what that means is all levels of care are prioritized in the same way that crisis services care is. So the crisis line, mobile crisis teams coming out, but having a living room model, having the ability for individuals to engage in partial hospitalization, lower levels of care that they may not receive in a system that right now is very focused on the crisis itself. And what we talk about is that by providing living rooms, sobering centers, detoxification centers, and 24/7 alternatives for those with less acute needs, we are helping prevent those crises from ever happening. And by providing those services, you very clearly save your community money because you aren't allowing people to get so sick. And then when they do get the care, you're monitoring to ensure that they get the treatment they need and they don't fall through the cracks. And I think honestly, the other main piece that we see in community after community that is doing this successfully is data sharing and quality improvement. It's that idea that the data cannot be siloed on the criminal justice side or at the hospital side or at the seat. It just can't be caught in any specific spot. And the reality is that too often the systems don't allow that communication to happen. And on the flip side, what we see is when those data are siloed, you also have instances when individuals get caught up and lost to the system. I think one of the key components to a successful system versus unsuccessful system is how well they were able to provide consistent oversight. If that individual is considered too sick and too difficult to care for, and they leave the inpatient system without an effective treatment plan or coordination plan, step-down plan, and they're lost back to the system, too often we see that person end up in the jail. And effective systems, the systems that have really done a good job in addressing that population, have said, we are going to collect our data, figure out who are the individuals that we are serving least well, that oftentimes they're termed high utilizers or frequent flyers, sometimes pejorative terms, but just that idea that they are people with serious mental health needs that aren't being successfully treated in our traditional system. And the way that that population can best be addressed is through really focusing care on that population and ensuring that they are treated at whatever point they're at. And what that looks like on the ground in a community like Tucson, for example, what you see is that the contracts that are written, the behavioral health monitoring that is done really tracks, is that person being served at each of those levels? When they leave the inpatient facility, are they connected with a warm handoff with someone in the community, or are they lost? They end up in a homeless shelter. Why are they there? Why weren't they provided with housing resources, and why weren't they engaged in a different way? And if they end up back in a jail, what can be done to ensure that they don't end up in jail again? What resources need to be provided that weren't there to really catch that? Is it a substance abuse issue? Is it an SUD issue? Is it something that the system can catch? And I think what we see is that there does need to be a real focus on that side of it, because these are, by definition, some of the most difficult to serve clients. But when you combine the resources with that level of planning and oversight, you really are able to make a significant dent in the demand that law enforcement and other inappropriate systems are seeing. And when you take a holistic approach, you recognize that those savings, while they may not fall into box X, benefit the entirety of the system and can be redirected back into serving those other systems. It really does benefit everyone. And that takes systematic leadership from the top level. And it takes a real focus on saying we are going to move from crisis to care. We're going to get away from that idea of waiting until someone reaches that point of danger or violence that sometimes triggers treatment, and move to a system that says we need to prioritize this population because we know otherwise they're going to keep getting very sick in our system and inappropriately receiving a significant amount of resources that they otherwise wouldn't need. So with that, I'm going to turn it over to Judge Leifman to talk about the specifics of what goes on in his community and how it works to address those issues that I identified previously.
Thank you, John, and it's always a wonderful pleasure to do a program with you. And Naomi and the rest of the organization, thank you very much for inviting me here today. There's a lot I want to cover. I'm going to try to be as succinct and clear as possible. But I wanted to start off by saying this isn't a criminal justice problem. Unfortunately, it's become a criminal justice response. In that what you find, I've been on the bench for over 20 years, and in many ways, the criminal justice system turns out to be the repository of many failed public policies. For some reason, society has expected us to fix those societal problems, and frankly, we just can't. Because these issues, particularly as they involve people with serious mental illnesses, are beyond our scope. And so what this really takes is a new approach, and it really requires us to rethink and re-envision the problem. And so what I would say is that in many ways, the problem has been is that we have applied a criminal justice model to an illness. And so nobody should be so surprised that it's failed so miserably. What we need to start thinking about is how do we apply a disease model or a population health model to an illness? And if you start to look through that lens, you're going to start to see much better solutions. So we started our project in 2000, so 20 years ago, after I had a very difficult case in court where the defendant turned out to be a Harvard-educated psychiatrist who had a late onset of schizophrenia. He ended up getting arrested on a low-level misdemeanor and spent weeks, if not months, in jail, only to be released back to the street without any services. And it really became a window to us about everything that was wrong with our system. And so what we did is that year, we convened a summit. And I think that's one of the best things about being a judge is you invite people to a meeting and they're going to come even if they don't want to be there. And we brought in all the traditional and non-traditional stakeholders who normally did not speak to each other. We brought in outside experts to help do the convening through what was then referred to as the GAIN Center, which is Policy Research Associates in New York. And we spent the first half day of this 2-day summit mapping out how our criminal justice system intersected with our community mental health system. And what we found is that it just did not, is that we were embarrassingly dysfunctional. And the classic example was we would arrest someone on a misdemeanor, they had a serious mental illness, we immediately ordered competency evaluations because we didn't know what else to do. They spent weeks, if not months, waiting for the evaluations. They'd come back. They would be adjudicated incompetent to stand trial. We had no misdemeanor competency system, so we would release them back to the street. And it was foolhardy, it was dangerous, and it was ridiculous. And it was very damaging to the people we needed to help as well. And so what we decided is that we would take a 2-part approach. If I were to do this again, I would take a 3-part approach. And the 2-part approach that we took was, A, how do we reduce the number of people coming into our system so that we could do a better job for the people that did come into our system. And clearly we looked around the country, and the Memphis model of crisis intervention team policing was the best program for us, except we are a huge county compared to Memphis. We have 36 departments, not one, 3.5 million people, very big community. But we got started, and after 20 years, we now have the largest trained CIT program in the country. We have over about 7,600 police officers now trained in CIT at all 36 at our departments. John made a very good point. It's not just about training. We've also have a 4-hour training program for all of our police chiefs and their majors. We have a 16-hour training program for our 9/11 call takers. And then we have a liaison officer appointed at each department and substation who meet regularly with our providers that have really empowered our law enforcement. So they actually come to the meeting with names of people that they've tried to address, and it gets elevated immediately. So everybody is on the same page. And for such a large county, it's amazing how nimble we've been able to be. Just to give you an idea, we keep data on every CIT call that our 2 largest departments out of the 36 make. They probably cover about 65% of all the calls. And that would be the City of Miami and Miami-Dade Police Departments. Over the last 9 years, from 2010 through 2019, those 2 departments handled 105,268 mental health calls. And out of those 105,268, they only made 198 arrests, which is stunning. And so the number of arrests in Dade County as a result of this program started at a high of about 118,000 when we began. And today, pre-COVID, we have about 53,000 arrests. Our jail audit has shrunk from about 7,300 to 4,000 pre-COVID. We've closed one of our 3 main jails. And when you talk about this, you really have to be intellectually honest. Taking 100, 200 people out of a jail doesn't save money. But when you close the jail, you see actual savings. So by closing one of our 3 main jails, we have seen an actual savings off the county book of about $12 million a year. That's $84 million since it closed. And the county has been phenomenal about reinvesting those dollars back into our system. The program, the CIT program alone, has saved the jail, the county, 300 years of jail bed days. The number of police shootings has precipitously dropped as well. We did not start this project looking at disparity issues, but I will tell you, when you do this program right, it has a huge impact on those issues. And so our police shootings, we did an analysis recently with the City of Miami. They had 90 police shootings the 5 years before CIT, and then the following 5 years it dropped to 30. And really, the first year of that before everyone was trained, still had 12. So the police shootings, for the most part, almost stopped in Miami-Dade County at this point, which has really been wonderful. Because if you look at the data, sadly, most of the people that do end up getting shot and killed by police are usually people with serious mental illnesses. And so by addressing these issues more appropriately and helping to avoid the escalation of a situation where deadly force or use of force is needed, our law enforcement has become incredibly proficient at identifying people in crisis, de-escalating the situation, and transporting a person to a crisis unit rather than arresting them. And it's had a huge dividend. Now, the one thing, I'm going to stay on law enforcement in a minute, and then I'm going to talk about a couple other components of this. The other thing that we had not anticipated, that when you're building a new system, I think you should, which is incredibly important, is the level of PTSD among law enforcement officers and trauma. So my CIT coordinator gets 150 calls a month from law enforcement officers that she has trained for their own personal mental health issues. And now it's up to about 250 post-COVID. And it's critically important. And it also explains why sometimes you do have some of these, what people might perceive unnecessary shootings and use of force. And so we have to address a lot of these issues. Yes, race can be an issue, but also PTSD can be an issue. And so it's just trying to look at this more holistically and look at the research and the evidence. And so one of the programs that we set up as a result of what we do is we now allow, through the permission of the department chiefs, our law enforcement officers to get treated outside their departments. They're very skittish about going to the departments for help for all the obvious reasons. And we've worked out a program to get them help outside, and we're allowed to keep it confidential as long as they're not suicidal or homicidal. And it's worked out incredibly well, and it's made our law enforcement officers so much more empathetic to this issue and the population that they're helping. We also have another component, and that's a post-arrest diversion program, and that's very sophisticated. We've changed the screening tool at our jail, and if someone is identified as having a serious mental illness, everyone is now screened using a validated tool. They see a psychiatrist that day if they're identified. And if they're on a misdemeanor and they meet criteria for our civil commitment, within 3 days of the arrest, they're transported by our Department of Corrections to a crisis stabilization unit. We have a collaborative agreement signed with all of our stakeholders, both private and public. And they are transported by the Department of Corrections to one of these facilities. And because they're on a criminal hold, the 72 hours of the civil law does not apply. So what we do is we actually reset the case for about 2 weeks, which for a lot of these folks, that's what they really need. They don't need long-term, but up to 72 isn't really that effective either. And then a member of our team goes over to meet with them. They've all been trained in motivational techniques, and they're offered a chance. And what they're told is, look, if you come into the program, you will not get rebooked. You will be picked up by Department of Corrections, and you will be driven directly to a courtroom. And when they get to the courtroom, one of our 8 peers will be waiting for them. And these are people with lived experiences. 4 of them are graduates of the program. And they're waiting there with food, with water, with medication, and clothes. And they begin to reestablish relationships for so many people that have had their relationships severed. People don't realize, but for so many people with these serious mental illnesses, by the time they get arrested, they also often have clinical depression on top of their serious mental illness. And it's not always that they don't want to take treatment. Sometimes they don't care if they breathe. And so you have to kind of break through that to begin that engagement process, and our peers do an amazing job with that. On a misdemeanor, there's a staffing done with the state attorney and the public defender, and it's not a one-shoe-fits-all depending on the prior, the charge. We do a criminogenic risk assessment using what is called ORIS, which is the Ohio Risk Assessment System. If they are a low-risk individual, we try to get them out as quickly as we can, sometimes just drop the charges and let them go home, because the data is going to show you that they don't need court supervision. In fact, court supervision may make things a lot worse. They may miss appointments, they may miss court, they may end up getting arrested unnecessarily. And they end up, meeting high-risk people that are more likely to commit crimes and who are going to want to take advantage of them and teach them how to commit crimes. So you want those folks out. These systems should try, if they're going to be in the court system, focus on the moderate to high-risk people. And so on the misdemeanor, the average is anywhere from 3 to 6 months. They're put in through a whole array of services. We provide them housing, case management. We get them their medication. If they're not qualified for federal benefits, we have a program called SOAR, S-O-A-R, which is a way to expedite federal benefits. We get them on their benefits. We assign them a peer. The county gave us a car, and that, right from court, they're going to be transported to where they're going to be staying, and we can start working with them. A felony case, it may take, we do nonviolent felony cases as well. They get transported out similarly. They have a peer waiting for them as well. And we have a whole engagement process and all the services and all the essential elements that people need for recovery, which means they're going to go to meaningful day activities. They're going to get supportive housing. They're going to get supportive employment if they're up to the task. Most of the folks that come into criminal justice are co-occurring, meaning they have both mental health and substance use disorders. So we're going to get them both treatment for their mental health and substance use. We also have a couple other post-arrest diversion programs. One is, which John really likes, is we were able to get the legislature to extend jurisdiction for assisted outpatient treatment for misdemeanor criminal defendants for our county court judges. So we now do AOT. Look, there's not a one-shoe-fits-all. There's not a, I don't like to use the term silver bullet because it's a terrible term, but there's not one way to just fix this. You have to approach it from many, many different sides because these are mental illnesses. It's not a mental illness. And so people have different needs, different illnesses, different criminogenic risk factors. And so if they are up on the criminogenic risk side, we're also going to make sure we provide cognitive behavioral therapies along with their serious mental health treatment. With our AOT population, our criteria is pretty narrow, but it's for that homeless guy that you've arrested a million times. We had a study done by one of our local universities, which should help you understand you don't have to fix the whole system at once. If you start to focus on the people that are accessing the system the most often, we can save a lot of money up front and start to reallocate dollars to have a larger impact. And so we had a study done. We sent the names of 3,300 people who had been arrested in Miami-Dade that had come through our program that we knew had serious mental illnesses. And the university has access to all the arrests in Florida, all the Medicaid, Medicare, and all the civil commitments in Florida. And they narrowed it down to 97 people, primarily men, primarily diagnosed with schizoaffective or schizophrenia type disorder, primarily homeless, primarily co-occurring, who over 5 years, these 97 people were arrested 2,200 times. They spent 27,000 days in the local Dade County Jail, 13,000 days in a state-funded psychiatric program, cost taxpayers about $14.7 million, and we got nothing out of it. And so the problem is, and John touched upon this as well, is that most of the money in mental health goes to acute services. That's jail, that's crisis stabilization units, and competency restoration. None of that does anything to help people recover and keep them in recovery. In fact, we did an analysis in Florida that showed our legislature that we spend easily $200 million or more dollars a year in criminal justice-related mental health than the state spends in services to keep people out of those systems. And in Miami-Dade, just to give you an idea, we spend a whopping $636,000 a day. That's $232 million a year just to warehouse people, 2,400 people with mental illnesses in our jail. It's not only offensive and horribly ineffective from a cost-effective purpose, but we're hurting people and we're not helping people recover. And so you need to start thinking, okay, so what's going to work? And those elements of day activities and case management and peers really, really help. And what I was going to say for our assisted outpatient treatment program, we put individuals that meet criteria on long-term injectables, which the patients actually prefer. They don't decompensate quickly. They have greater insight. It's every judge's favorite calendar because you watch people within 2 to 3 weeks who have been incoherent for decades and homeless sometimes for decades, all of a sudden have insight into their illness, and we have an opportunity to really help people in their recovery. We also have an alternative to competency restoration for felons, for people charged with felonies. That's also, we use a long-term injectable, and then we put them in our felony diversion program. We don't really run a mental health court per se. What we run is a diversion system, both pre and post arrest. The court is a small part of what we do, but it's an effective part, but it's only effective because of the other components that are in the program. And finally, I wanted to say 2 things. One is, if I were to do this again, we know so much more about the mind in children today and trauma than we knew 20 years ago when we set this up. And so if you're not familiar, you may want to become familiar with something called ACEs, which is the Adverse Childhood Experience Assessment Tool. It's unbelievable because we know that kids that have like a score of about 4 and above have almost 100% chance of having a substance use disorder and or a mental health disorder. And we know, for instance, that 92% of all the women in jails and prisons in the United States with serious mental illnesses have horrible, horrible histories of trauma, mostly sexual abuse as children, mostly familiar, going on for long periods of time. 75% of men in jails and prisons with these serious illnesses also have very serious histories of trauma. It may be domestic violence, it may be sexual abuse, it may be witnesses to violent crimes. And a young brain that's exposed to trauma that basically is overdosed with cortisol is damaged even more than an adult brain. And these kids are victims, we never took care of it, and they end up growing up into our system because we didn't address it early enough. And so what I would have done is and I heard that the schools were represented today, and I think that's wonderful, but they should be, in my opinion, doing assessments in middle school of ACEs and identifying trauma earlier, and getting kids treated much earlier so we keep them out of these systems. But I also think that we need to modernize our civil commitment laws and our criminal laws. We should be actually codifying diversion. So when people meeting certain criteria come into the criminal justice system, they get moved over to the civil system immediately. And we need to be looking at the science. We know that there's some long-term damage to the brain if it goes untreated for long periods of time, particularly for people with bipolar disorder and sometimes schizophrenia when they're in psychotic states. And we need to have the laws reflect that and not let people wait so long to get treated if they need to get treated. I'll stop there so we can open up for questions, but I do appreciate everybody's interest in this. But I really think we need to look at the whole system, not just the law enforcement side of this, because what we really need to be doing is reducing the number of people coming in. And as John also talked about, we're looking at a co-responder system. And if someone wants to ask me about our new amazing technology system we're about to put in place in our new building we're building, please do so, because we're about to go to a whole new frontier. Thank you.
Thank you so much for speaking to us. I have been taking tons of notes, but let me start off with a question. And if anybody else here wants to ask a question, there's a little icon there on MS Teams and showing a raised hand. Like, I guess, every place, we have our bureaucracies and our silos. So we have the fellow who's getting out of jail. He saw the jail psychiatrist. The jail psychiatrist gave him some medication, and he gets out, goes to community mental health. The HIPAA is preventing them from seeing what medication he got because that psychiatrist is not an employee of community mental health. How did you, I mean, it's stupid. How did you break down those silos in big Miami-Dade?
So a couple things. after we had this summit, we put together systematic change, and we actually put together a written collaborative agreement. And we required everybody, and these are people that could, make systematic change: county commissioners, Department of Children and Families, the court, state attorney, public defender, etc., actually came in and signed the document saying what they would do differently to break what we were doing and start a new system. And we just picked an arbitrary date and we began, and it's been generations of prosecutors and defenders. They don't even realize how different it was 20 years ago. This is how we do it. But going to the HIPAA issue, first of all, HIPAA does not apply to the criminal justice system or to law enforcement. But there's an easy way around all of this. We have the individuals sign releases, and it's not a hard deal, and they sign it easily. They want to get better most of the time. It's not what people always think. And so sharing of information, and we have a managing entity system in Florida, and so all of our community providers are on this one network. So they all have agreements with each other to be able to share data as well. So you can bring people in. HIPAA was written not to prevent the sharing of information, but to show people how to share information. And in many ways, and I don't mean to disparage anyway, but sometimes I find providers use it to, avoid accountability. It's not there for that. And just to make you all feel better, there's never been one criminal prosecution in America for a HIPAA violation. As long as you're not trying to do anything terrible, you're going to be fine. But the best way to address it is to talk to each other, work out collaborative agreements and data sharing agreements, and have the individual sign a waiver. It's not nearly as hard as people think it is. And when you come into our managing entity system, you sign a waiver, and it works very, very well.
Thank you for that. I'm going to go back and remind everyone that HIPAA doesn't apply. John, a question for you.
Doesn't apply to everybody.
Right. Okay.
Who it applies to and how to use it to help protect them.
Okay. Got that. We have talked a little, you talked about different police departments, different communities, and how they're attempting to decriminalize mental illness. Do you have any models that you know of where crisis responders are associated with the fire department rather than the police department? And what is your view of that versus having community mental health or some other agency or nonprofit do the crisis response?
That's a great question. And I'm going to take just one moment because my team will be very upset if I don't. We have a webinar coming up on the 18th through what we call our learning network that brings different communities together talking about issues. And the focus is going to be on data sharing in the context of federal confidentiality laws, especially how to coordinate around those. One of the examples they'll be talking about is a process that they used in coordination with the state of Ohio to allow the state to sort of be the clearinghouse for much of the documentation. And that Ohio has very kindly been willing to share with other states. So there's a resource I think that could be really useful for folks. Now, your question I think is a really good one. And I've talked about these issues with John Delaney from the Arlington Fire numerous times because he's done a great job in saying first responders, even beyond law enforcement, really need to be trained up and a part of this conversation. And in too many communities, what we see is that they sort of are left aside, that this becomes a police issue, or if they are involved, the conversation just doesn't happen as well. I think this is obviously a huge issue in the District of Columbia, where the majority of calls involve fire first when it's a mental health issue. One of the models I really look to comes from Salt Lake City. They have done a really nice job of pulling these issues out from being a law enforcement response and even moving beyond making them either a emergency or ambulance response, and have said, we have a population that we keep track of, that we are serving regularly. And when we get these mental health calls, we don't send the fire department as we traditionally do. We don't send ambulances. We send this specially trained team of mental health response agents who come in an unmarked vehicle, who don't have the sirens going, because that can be very stigmatizing and add to the stress level, and really help engage that population. Actually, have moved so far as to they don't use handcuffs and transport, even when law enforcement are involved. It's a really interesting model that's done a nice job in engaging all ends of the first responder process, and really saying, we're going to get away from a model that says, there's a mental health call, we have to have some sheriffs on scene, and they have to be there to secure the scene. They've really moved to a different model, which has been really interesting to see in practice because it has been very effective.
Great, thank you. Judge Leifman, a question for you. You talked about CIT and that a high percentage of your law enforcement have been trained in CIT, and there's even been special training for your 9/11 dispatchers and so forth. Arlington does have a very high percentage of its police force that's been trained in CIT. What refresher or retraining do your law enforcement folks get? Or is it a one-time thing?
Oh, no, it's quite regular. I have a full-time CIT coordinator that works for the court. And so she is constant. She does roll call training. She does a refresher course. It's constant and ongoing. And I think what's critical is the quarterly meetings that she has with the liaisons from each department and the providers. So they'll have a meeting, they'll show up, and law enforcement may say, hey, I've been out to Steve Leifman's house 4 times already. He has a serious mental health issue. No one is addressing him. This is ridiculous. They may send a mobile crisis unit that afternoon. And it really empowers the police, which you want to do because you don't want them to arrest, because they arrest when they get frustrated and nothing else is working. But we're getting really close to move towards more of a co-responder. And we've also set up a separate unit through Miami-Dade Police Department. It's our, oh gosh, the name of it just escaped me for a second. I'll think of it, threat management program. And so they go through, there's about 10 detectives actually assigned to this unit, and they review every single CIT call every day. And there, as you can do the math, there's quite a few. In any case where there may be a weapon or a threat of any kind of physical harm, they then do a follow-up, and they go out and see the person. But they're not there, they send CIT out, they're all trained and usually go in plain clothes. And they're like, hey, I'm so-and-so, I work with, Miami-Dade Police. I just want to see how you're doing, what can I do to help? Make sure, and they meet with, they have the person sign a waiver, and then they go meet with the managing entity, and they bring in the services to the person no matter where they are. And then they start managing the individual. Now, what we're about to do is they have developed a platform, because Miami-Dade's pretty sophisticated in terms of, we have an electronic arrest affidavit. And so they're in the midst of, and I give Miami-Dade Police a lot of credit for this, they've created this new platform for CIT, and that information will then go on the platform right away as they fill out the form. And there'll be machine learning, and they will collect all of this data. And every single day from every department, hopefully, once we get this fully running, we'll have all this information, and John will be happy about this too. It looks like we finally have our civil court ready to set up an AOT system. And so those that meet criteria that are coming up in this threat management system will get taken directly into that system. So a petition can be filed, they'll be assessed, petitions will be filed. And if appropriate, we could use AOT. but it's so closed and coordinated, it's mind-boggling that a large county like ours can pull something like this off. And so we got a federal grant to help pull it together. It's through the courts, it's through our managing entity, it's through law enforcement, and they've been working really hard on it, and it's just about ready to get kicked off. Now, the other thing that we do too is we have a jail in-reach program that we run with our Department of Corrections, where our staff is actually in the jail helping identify people that may slip through. And that way it helps expedite them and gets them out of jail much more quickly than if they kind of got past the first door.
Great, thank you. For both of you, a question about hospitals, because both of you emphasized the need for early intervention and treatment. And yet, when people do recognize that a loved one needs treatment, they often, if they're able to get a bed at a hospital, the person is released far too soon. They are not stable. Mm-hmm. Have you, I'm wondering if the judge has worked with his local hospitals to prevent that sort of revolving door. And John, I'm wondering if you have examples across the nation where people have worked out suitable arrangements with hospitals.
Go ahead, John, and then I'll go.
Sure. So this is one of the key components to the conversation. I think in community after community, what we see is that any specific breakdown, but especially at the hospital level, then triggers a sort of a follow-on of the system breaking down. Quite simply, if you don't have enough treatment beds, people end up in the systems that aren't designed to care for them. They end up in the jails and the emergency rooms. And so what we are seeing in communities that have an effective level of treatment beds is actually sort of the opposite of what you'd expect, that by having more robust community services plus inpatient beds, you actually end up with people spending fewer nights in hospitals. Because when you do have to go to an inpatient facility, you're able to stay there for a little bit longer, the care is more coordinated, and you end up with a much better ending. Now, one of the key components of this is having those higher level services for people who need longer term stays, especially those most intensive services, those IMD services. Those are services that are typically done in what's known as an Institute for Mental Disease, but a facility that specifically is focused on providing mental health care. Now, there is a federal law that had prevented Medicaid from paying for those services, but that regulation was changed last year, and states are now actively able to apply for a waiver that would allow the federal government to reimburse for those inpatient stays. That is a game changer in this conversation. One of the things that we've seen in many of the communities in which a successful, fully coordinated system has been able to be put into place, they have taken advantage of waivers to get rid of that provision. And so that's one of those sort of keys of the kingdom to really get the system going, is not having to take on those entirety of cost at a state level, being able to share some of the costs with the federal government. And one of the nice aspects about it is there is a very specific application process, for lack of a more specific term, that community has to go through that says, here is how we are not just going to push everybody into hospitals. Here's how we're going to coordinate with the community. And so I think it addresses some of those concerns that people sometimes have of, oh, the system is just looking for a way to throw people back into institutions. And it really says, well, no, what we need is a specific component of the system that for too long has been sort of ignored because it was a lost leader. So that's one of the key pieces that I would recommend, is that making sure that Virginia takes advantage of that IMD exclusion waiver and submits an application to get those resources covered, because it is, for all intents and purposes, free money for one of the most expensive aspects of treatment in the system, and it's really a no-brainer to go after. Judge Atkins.
Great, thank you.
Couple follow-up points on that. One is that right now, prior to this change, states could fund 16 beds in a facility using the Medicaid dollars. The waiver allows you to expand it beyond that under certain circumstances. The problem is that if you don't have a good continuity of care, once they leave hospitalization, just like once they leave jail, they fall back into the same terrible system and end up needing long-term care again. And so you have to really address the whole system. And I will tell you, an analysis was done by the Florida Mental Health Institute, the same people that did that study of the 97. And what they found, which was really shocking and disturbing, is that for every time someone is involuntarily committed in Florida at a crisis stabilization unit, it increases their probability of getting arrested by 12%. So if you're arrested if you're involuntarily committed 4 times in Florida, you have about a 50% chance of actually getting arrested. And what they found is that our civil commitment system, and this is pretty much true with every civil commitment system, is just another fragmented, disjointed system of care that doesn't address the real needs, and just like jail. And so what happens is people think, oh, they're going to an emergency room, just like, I broke my arm, they'll fix me up and then I'll be okay when I leave. It doesn't work that way for people with mental illnesses, and the criteria are so harsh in many states, including mine, that they go in and they may be there an hour and nothing really changes. So you have to have this whole system put into place. And so we have a written collaborative agreement with all of our providers. We don't use, one good thing we do in Florida, and we don't do a lot, is that we don't use emergency rooms at a primary hospital as our crisis unit. We have standalone mental health crisis stabilization units, and they work better as far as I'm concerned. And we use Medicaid dollars to fund it. And so it really works pretty well. And the problem is you have to make sure there's a warm handoff once they're stabilized and they're leaving. And you have to have a state law where the criteria has been modernized that isn't just based on dangerousness to self or others. So it's a little complicated, but we could do 4 hours of a session just on that. But part of it is, have a summit, start to talk about these things, look for where the gaps in the system are, figure out how to plug them up. You'd be amazed. Some of the resources may already exist. People just don't know how to access them. And you can have a major impact. So we do pay very close attention to this. We do now work with, Jackson Memorial. We're lucky because they're a public hospital. They get a lion's share of the very difficult cases. They also do the jail population, so they're on one computer sharing system, and they will file petitions for AOT in our criminal system for this population. So it's really about communicating and collaborating and getting to know the different stakeholders and partners and working with each other to make the system work. And look, we've been doing this 20 years, and we joke we're a 20-year overnight success. You don't have to fix the whole thing tomorrow. Just start. And you will see as you get to trust each other and collaborate with each other, it will expand. And there's a lot of areas that are easily fixable up front that will save money, save resources, and get people to start to buy into a bigger system. I mean, I know we're probably almost out of time, so I'll do this really quick. But we've done so well that our county, through bond issues and $8 million from Jackson Memorial, we have a total of $51.2 million. And we're halfway done reconstructing a facility, 181,000 square foot building that's going to be a one-stop shop for the most acutely ill that keep recycling through all these deep-end acute systems and start to get them the services that they need under one roof, including primary health, dental, eye. There'll be a courtroom in there. There'll be psychiatric crisis. There'll be short-term residential. There'll be housing. There'll be trauma services, a living room, which John referred to, where people can go hang out and just, start to, get their stuff together, and engagement. And instead of just kicking people out the street, whether it's through crisis care or jail, we will then slowly reintegrate people back to the community in recovery with all the supports that they need. They can live there for up to a year if they want to. And so what you're going to find is you will be able to make some significant improvements. You really can. But there's still going to be about 20% of the population left at the end of the day that are too sick for the existing resources. And so you really then have to start thinking, okay, we've saved these dollars, we've done this. Now what do we need to really address this really acute population that we haven't been able to finally get to? But it's all doable. These are recoverable illnesses. They're not death sentences. And we just need to do a better job identifying it earlier, having better long-term case management systems, and not using a criminal justice system to deal with the ills of society, but use these population health systems that we know work.
Thank you so much. I have one final question, and then I want to see if anybody else has questions. We do hear from families who have a loved one with developmental disabilities or autism, and they worry about calling law enforcement when there's a behavioral issue. Have you both found, both John and Judge Leifman, have you found that when a community makes changes, even if it's focused around mental illness, does it benefit also those with substance abuse, those with developmental disabilities, or do we need some special solutions for each of those populations? Over to you, John.
So I think one of the really nice things about both the CIT and then broader just diversion and deflection training is that we hear from officers all the time, law enforcement all across the country, that says that it provides a level of understanding and ability to engage in a different way that they find useful every day on the beat in a variety of situations. And I think that's one of the realities. Now, I would never say that that's enough. I think the reality is, especially for those various populations, I think there is obviously a need for additional resources to make sure that they don't come into contact with law enforcement whenever possible, because again, it's just an inappropriate use of law enforcement's time to be responding to those sorts of situations. But what we do hear over and over again from law enforcement is that the training is really useful. I come back to the example of, and many of the folks on this have probably participated in this, but the CIT training that provides headphones that has noises and sounds and mimicking command hallucinations, and then has another officer attempt to give you commands that you then follow as and try to just take basic commands of, show me your hands, stand, basic things. Just how eye-opening that experience is, because it lets you know just how difficult some normal day-to-day things may be for someone who has different abilities that a law enforcement officer may not come into contact otherwise, and that's really useful.
Great, thank you. And Judge Leifman, your camera may be off. At least I can't see you.
I don't know how that happened. So yeah, I agree with John. The more fragmentation, the less likely things are going to get done right. So what we do is we have at least a 4 or 5 hour track on autism, because autism is part of DSM. And we actually are very fortunate. We have mom and her son who is autistic and not very high functioning on the scale. And they actually participate in the class with the law enforcement officers. And it's pretty amazing and wonderful. But we also then teach the officers to be able to distinguish between someone that may have an intellectual disability and autism. And then they're given the resources on who to call. And we have an agency which is the Agency for Agencies for Disabled Persons, who legally are responsible for that population. And they actually have more money than most of us. And they go in, and if the person meets their criteria, they actually take physical custody of the case and take it from there. So it's really about teaching law enforcement where the resources are, who the right people are, and then getting them to access those right individuals. But I think a key to this, and I think we're all starting to move there, is this re-envisioning of having law enforcement be more of a backup when we can, and having civilian providers coming to the home and transporting. I mean, think about it. You call the police, they come out, even the best of law enforcement, and so many of them do a really great job, but they're going to put you in handcuffs and put you in the back of the car, even if you haven't committed a crime, just to transport you, because that's the standard operating procedure, to a facility. And so what happens? The young man or woman is horribly embarrassed and stigmatized. The neighbors think they committed a crime. I mean, you're going to do that to someone that has a heart attack or cancer? It's ridiculous. And so we shouldn't think about it any differently, and we should have a civilian transport come and take them to wherever they need to go, not in handcuffs, and teach people how to talk and de-escalate a situation, and try to use law enforcement always as a last resort on these situations if it's very violent or there are weapons involved.
Great, thank you. I'm seeing a couple more questions. Dave Fitzgerald, over to you.
Hi, Judge, I've got a question for you. We're kicking off in Arlington a behavioral health docket at the end of September. It was structured to handle misdemeanors primarily, but there is an ability for the Commonwealth's attorney under his or her discretion to also include felons. We've had personal family experience with serious mental illness calls that have turned felonious because of the response of the police. So I'm well aware of how situations can get out of control, and people who've never had a criminal record before in their life, much less a parking ticket, get stuck with 4 or 5 felony charges due to difficult situations with the police. Where are you with your experience in advising judges and prosecutors to divert the mentally ill who are maybe not misdemeanors, but are clearly would benefit from the mental illness, even though they're felons?
Yeah, so we promote it tremendously. And, one of the big mistakes in our system is we tend to judge these cases based on their charge, not the degree of their illness. I've had misdemeanors who could be the most dangerous people in society, but at that day, they just were pushing a stolen grocery cart. And I've had people charged with felonies that wouldn't hurt a lamb. And just because the discretion and what happened, they pushed the officer. They'd been off their medication for a couple months and never had a record before. So we've gotten very good here in Miami-Dade about teaching our law enforcement. And you know how I know it's working, and you know how I know that there's been a cultural shift? Because in the data I cited earlier, we also keep the number of police injuries. And the number of police injuries are about 15 to every arrest. And so they are letting it slide, and they're not making that arrest because you're now the cool cop if you don't make an arrest of someone that turns out to have a mental illness, and you're kind of the wimpy officer if someone with a serious mental illness and psychosis pushed you and you didn't get hurt and you arrested him for battery on a law enforcement officer. And we can see that in the data that has occurred. And from a post-arrest system, we take all those kinds of cases, both misdemeanors and felonies, and we are a pre-adjudicatory system for the very reason you talked about, is we do not want to criminalize the mental illness. We don't want people to end up having a record because of their illness, because then it makes it harder for them to get employed, it makes it harder for their recovery, and, it makes it harder for them to get housing. And so you don't want those barriers unnecessarily. they're sick. And if we get them treated, they're going to do well and they're going to do fine. And that is the goal of what we try to do. So you don't have to take a plea to come into our program. I would, and kudos to the Commonwealth for finally setting up a mental health court. But remember, they're not the end all and be all. I'm not a huge fan of mental health courts. I'm into a diversion system because generally they only take about 1/10 of 1% of the people that need it. And they often take the wrong 1/10 of 1%. They take low-risk people because, they think it's a safer bet and they don't have to worry about someone going and doing something terrible. But what the data shows us is that person was going to be fine without us, and they're going to be better off without us if you just get them hooked back up with a treatment system. The moderate to high-risk people, and when I say that, not to do anything, moderate to high risk doesn't mean they're at high risk of committing a violent crime. It just means they're at higher risk of committing a crime. And so those are the people that should be under court supervision. And so we take all misdemeanors and we take pretty much all third and now a lot of second-degree felonies.
Okay, thank you very much, Judge. That's very helpful.
And I would suggest, and it'll give the prosecutors some, comfort to use these criminogenic risk assessment tools, not to keep people out, but to figure out what kind of treatment plan that they're going to need. If they do have a criminal background and they have a substance use background, they're most likely going to need cognitive behavioral therapy on top of their mental health treatment. And just doing one without the other isn't going to give you the outcomes you want.
Thank you so much. So now we're going to look into a diversion system. I think we have one on the books, but maybe it's not that robust yet. So we'll work on making it better. I see another question. Kim Phillips, can you state your question?
Sure. Thank you so much for this presentation today. My question is actually for both of you, starting with Judge Leifman first. You said that the Memphis model was the model that fit best for Miami-Dade. So what was it about that model versus some of the other models that you looked at that felt like this was the perfect fit? And for Mr. Snook, you talked a little bit about the Salt Lake City model. What is it about that particular model that you like as well?
So thank you for your thoughtful question. Part of it was we started 20 years ago and there weren't any other models. But CIT also had a lot of research and it was a validated program. The University of Tennessee did some really great work. And we really, at the time, thought that was, in fact, the best program. Now, that we've evolved, we've gotten smarter and more sophisticated, I still think it's important to train CIT officers. I certainly wouldn't eliminate it, but I am really interested, and my county's going that way, and we're helping them go that way, with some type of co-responder model where, civilian providers would be the first responders. There's a program in Houston where if you call, the 911 call taker asks a whole series of questions. If they don't think law enforcement is needed, they call the provider themselves. They stay on the phone until the warm handoff is made and everything is taken care of. And a provider goes out and responds to the call, saving law enforcement a lot of time, energy, and resources. And like I said, helps avoid, some of the other risks that have kind of been talked about where a situation may escalate, where use of force or deadly force gets used. And you avoid the stigma and embarrassment of having to transport somebody in a police car. And so I still love our CIT officers. I still love what we do. But just like everyone else, we're going to grow a little bit more, and we're going to find a better way using this co-responder model next, I believe.
And picking up from Judge Leifman, I think one of the really interesting things, I work really closely with the board of CIT International, and they put out a best practices guide that's available on their website if you go to citinternational.org. And one of the really interesting things about it is that they themselves have moved to a model that really says law enforcement should not be first response in most of these instances. And I think that is a really interesting place for CIT International to be saying what we want is to move away from our program being your first instant in these situations, that we want in most instances, and our research has backed this up, about 2/3 of the responding officers said that the people that they were either picking up or transporting were not dangerous. They did not perceive them as to be dangerous enough to be requiring a law enforcement response. And so to actually answer your question rather than just talking, sorry, Dave, I think one of the key things is not that I think Salt Lake City is better. I think if it comes down to it, I'm really often recommending Judge Leifman's model probably the most, is one of the ones we talk about very much. But I think at the end of the day, it's the program that makes the most sense for your community. In Arizona, there's a program I talk about quite a bit, and they have not moved to a law enforcement less response. What they have done is they've taken what they call the mental health support team, which is police officers that do nothing but mental health response. And so they have taken sort of a quasi mental health law enforcement tack. And that team, what they always say is, we don't have to do bank robberies. We don't have to do anything else. This is what we do, is treatment. And they have collected data that shows just even simple things, like by having those officers on the beat, being able to visit someone every day or every week and see how they're doing, what they see is that they've been able to reduce SWAT team calls, that oftentimes, because so many people in that community had firearms, that if someone called in and was suicidal and was locked in their home, that had to be a SWAT call. They've reduced and almost eliminated those sort of SWAT costs simply by being engaged with that population. And that is a law enforcement team. That is not a change. They do coordinate with social workers and have a much more medicalized model than I think what you'd see in a traditional law enforcement response. But there are a lot of models, and it's just sort of making sure you understand what your specific community's needs and wants are. Dallas's Right Care program, for example, relies on law enforcement officers to secure the scene first and then provides that co-responder model. But as Judge Leifman was talking about, Houston's is entirely different. They have an entire specific section of their police force that does nothing but mental health response. And so we have a number of good solutions, but as you look at it, what it comes down to is, just like Judge Leifman's been saying this whole time, it's about a coordinated system that doesn't allow it to become a criminal justice responsibility, because that's the one thing we know doesn't work. That's where it breaks down, and you have to have that coordination across the system, and that's really that's the key to the success here.
And if I could just add briefly, I'm looking at our data. I told you we just got it updated, but about 40%, about 40,000 out of the 105,000 calls don't even go to crisis care. And so having an officer go out just for that is often a waste of time. If you could cut down half the calls just by having someone else go, that's a substantial improvement and lowers risk. And sometimes it's just giving the person a referral on how to get access to treatment and calming down the situation with some professional that's out there. So I think if we're going to transport, we have to really think about having civilian transport lined up and not having police cars, people transported in law enforcement.
Great, thank you. I think having civilian transport is something our state just funded maybe last year, but it's still, I think maybe just in one region or something. It hasn't reached us here yet. We're hoping for that. 2 questions just came in writing here. So one of them, how do you balance public safety interest with an individual who commits a crime that could have turned quite serious, but was entirely due to severe psychosis? Have you seen success for those whose behavior is completely changed by diagnosis and medication?
So, look, we're all about public safety. But I tell prosecutors that we have two choices, because number one, it's very rare that someone commits a heinous offense. So it's like in the single digits. And so 90-something percent, 95% of people with mental illnesses that get arrested are going to get released relatively quickly. So we can either release people with or without treatment. We know that the risks are much higher when we release people without treatment. And so if you want to improve public safety, the key is to figure out a way that when we return people to the community, that they're given access to treatment. And so just by trying to punish someone for their act without understanding why it may have occurred, to me does nothing except exacerbate the criminal justice risk. So if they're psychotic and then you stabilize them and you give them a year sentence, they're going to come out in worse shape than when they went in. And so one thing I'm harping on a lot these days is I don't think we should be doing nearly the amount of competency restoration that we do. It's foolhardy. It's an entitlement program. The states are spending billions of dollars each year for terrible results. And instead what they should be doing is reserving competency restoration for the most heinous of offenses, for people that do need to go to prison, and reallocating a lot of those resources to front-end services to keep people from ever ending up in our system. And when they do end up, diverting them into really good systems of care to get the level of services based on their need so that they don't reoffend. And I will tell you this, we have data to prove it. The recidivism rate of our felony diversion program fell from about 75% to 25%. It saved the county 84 years of jail bed days. And our misdemeanor recidivism is at about 20%. And so it is doable. It's our public safety is much stronger today than it was 20 years ago when we started this project. And you can just look at the number of arrests are in half since we started this project. And it's not like our population shrunk or got better. It's just we got smarter and started using a population health model to an illness.
Great, thank you. Last question is someone is asking about not guilty by reason of insanity and asking about whether folks who are, I think in this area they go to Northern Virginia Mental Health Institute, but whether those folks are getting adequate treatment since they, I guess, would have been convicted of a felony and now because of NGRI they aren't. Are they really getting the treatment they need? What happens with them?
We put out a report last year looking at this issue around the country. And unfortunately, what we found is that far too many communities are setting people up to fail, that you would have individuals who were released NGRI and then were never provided effective treatment. We highlight a number of processes and programs that are the most effective all across the country. There's some good ones in the Pacific Northwest especially, but what we found was that we actually even highlighted in many states instances where someone was found NGRI, failed by the system, and then they committed a second very heinous crime that because it was entirely preventable, because those are individuals who obviously were in need of care and the system completely failed them. But I'll turn it over to Judge Leichman. He obviously has a ton of information on these issues. So
first, I want to put in perspective. Nobody gets found not guilty by reason of insanity. It's less than 0.1% of all the cases. So no one should think that there's this great system out there that people are taking advantage of to avoid responsibility. It is really rare. And they are so sick that most sides are agreeing, and it's not this great court battle of witnesses, and it doesn't work like that. It's very, very rare. A lot of people are not competent to stand trial, and that's different than being actually found not guilty by reason of insanity. To focus in on that answer, John is right about making sure that you have adequate resources afterwards. And this is something that just makes me want to scream and laugh at the same time. So we have this amazing program here in Miami-Dade. And if you are found not guilty by reason of insanity, and it's usually for a really, really horrible offense, they're given top-notch services. They are given housing, intensive case management, they are monitored, they have to stay on their medication, and they've been around for 25 years, and they have almost zero recidivism rate. And that's the happy, smiley part. The bad part is you shouldn't have to kill somebody to get that level of service so that you don't reoffend. Those level of services should be available for anybody that's that sick. It's like, you know, you have cancer and we have a lottery system and we're only going to give treatment to 1% because they won the lottery. Why are we, you know, treating people differently from a different illness? And that's the irritating part that makes me want to scream and cry. Everyone should get that level of services if they need it. And if they do, we wouldn't have all these people in jail. We wouldn't have the police responding to all these cases. And most of those folks would be in recovery and have their lives back. And that's, you know, the heart of the problem is we don't do it that way. We wait till something terrible happens. And then we bring in all these expensive resources, which don't leave enough for everybody else at the front.
Thank you so much for that explanation and your real world experience. I wanted to give each of you a chance for a final comment, suggestion, whatever, if there's a topic you feel we missed, or John, starting with you.
Sure, thank you very much. I just want to thank the group for participating in this call and encourage the success that Virginia's already had and really taking these issues seriously and enacting reforms to continue to keep the pressure up, to work for more treatment beds and a more coordinated and comprehensive system. It's a real great opportunity that Virginia has at this moment, and I appreciate you all taking the time to really be engaged in these important issues.
So thank you, John, and I applaud and congratulate you as well for taking these steps. They're critically important. It's all about collaboration and cooperation. And the problem in America is if you've seen one community mental health system, you've seen one community mental health system. And everybody's a little different. And so there's not a switch we can flip to fix this. It requires this intensive collaborative process to figure out what's missing and then figuring out how to fill in the gaps. And so I would commend people to go look at steppingup.org, which is a program through the National Association of Counties, the Council of State Governments, and the American Psychiatric Association Foundation. I think about 500 counties have now passed resolutions representing almost a third to a half of the American population on stepping up to make the structural changes necessary. They have a lot of good information. If your county has not passed a Stepping Up resolution, I would strongly suggest you get them to do one. And then if you haven't done it, I'm a big believer in having a summit where you map out the gaps between these systems and figure out how to start fixing it. It won't get fixed overnight, but at least if you have a blueprint of what's wrong and a blueprint on how to address it, you can start to make those changes. And you just can't do a piece here and a piece there and expect it to get fixed. I mean, it's great you want to do a mental health court there, but it's more than that. And you know, you have to have the right people. You have to make sure everyone that needs it gets access to it. And so these summits help you do that by bringing in experts, either from Council of State Governments, Policy Research Associates, who are the experts in helping map out these issues so you don't miss anything. And then, you know, figuring out a collaborative agreement. And I really recommend you get everyone to sign it so that their name is on it, they feel committed to it. And, you know, we're not all going to be around forever. And so you want the change to outlast you, and it shouldn't be built around one person. I mean, I have an amazing team. I'm rarely in court with this stuff anymore. They do it all. It's way, I get to run around the country telling people how to fix it now because it's institutionalized. And that's ultimately the goal. And it should just be automatic. Just like if you break your hand, you go to an ER or whatever, it just should be automatic. We're not there yet, but there's good stuff coming, and I'm optimistic. And as terrible as this pandemic is, and it is, and people have to take it serious and wear masks and self-distance, but it also gives us an opportunity to fix these broken systems because it has laid bare how bad and disparate and horrible some of our systems are, and this is one of them. And we should take advantage of fixing this part of the system at a time when the jails are emptier than ever, arrests are lower than ever, and the biggest mistake we can make is allowing this to go back to where we were before the pandemic without the structural changes.
Gentlemen, thank you so much for spending your time telling us, kind of sharing your wisdom and also motivating us to improve. I really appreciate it, and we're all going to learn so much from it. I'm glad this was recorded so I can go back and listen again. Again, thank you so much for your time. And I've watched your things, and I appreciate everything I've seen about both of you.
Thank you so much. And quick question. Did I send you a description of all of our programs in Miami-Dade? If not, I'll make sure you have.
I don't think so.
I'll send it to you so you can distribute it out, and it might be helpful.
Great, that would be helpful. And for those listening in next, we're over our time, so next Monday at September 21st at 4 p.m., we have Joe Smaro from San Antonio Police Department. He's the subject of an HBO documentary, Ernie and Joe Crisis Cops, and also Tim Black from Cahoots in Eugene and Springfield, Oregon. So hope you'll join us again. Gentlemen, thank you so much.
Thank you. Have a great day. Bye-bye.
Thank you.
You too.